Hello, my name is Isabel Maria Andrade, and today I'm going to talk about the public health impact of inadequate birth spacing. Adverse health outcomes have been related to suboptimal birth spacing, and that's why the WHO recommends that women wait at least 2 years after a live birth before attempting to have another baby. Today we're going to look into the health risks that are associated with suboptimal birth spacing. Then we're going to look into the social demographic and behavioral characteristics that affect the occurrence of inadequate birth spacing. And then finally, we're going to look into evidence-based interventions that are culturally sensitive in order to prevent inadequate birth spacing. I'm going to start by giving you an epidemiological statistic that I find very striking. Between 2006 and 2010, 33% of US pregnancies were poorly spaced. This is important because mothers who space their births inadequately are at a higher risk of having premature babies. In a study that was conducted in Ohio in 2014, it was found that moms who had babies at less than 12 months were at a higher risk of having a premature delivery. Here we can see in figure 1 that the percentage of mothers with preterm babies was highest when the interval between births was less than 12 months, and it tended to be a little lower when the interbirth interval was 18 months or more. Other health risks that are associated with inadequate birth spacing include hemorrhage, anemia, third trimester bleeding, the rupture of membranes, and this is something that affects maternal health, but they can also be life-threatening as well. Moms who don't space their births adequately and have intervals at less than 18 months can be at a higher risk of having fetal deaths or of the fetus being a small size for its gestational age. A study that was done in 2013 actually found that the odds of infant mortality can increase up to 83% if women don't space their births adequately. Something very interesting that has been studied recently and has been documented in the literature is that there appears to be a relationship between short birth intervals and autism spectrum disorder. This is something new, something that has recently gathered the attention of researchers, but it's worth noting because in this graph of a cohort that was studied between 2000 and 2009, it was found that the prevalence of autism spectrum disorder was highest when the time between the birth of the first child and the conception of the second child was shorter. Here we can see that it's highest when it's less than 12 months, but we can also see that when the interval is very long, there also appears to be an increase of the prevalence of autism spectrum disorder. The mechanism of causality of this is not yet fully understood. In fact, it's unknown. That's why more research needs to be done about this, but it's important to know that it could be a factor of short birth intervals. As a whole, there are various health risks that are associated with inadequate birth spacing, and that's why we want to prevent it. In order to prevent it, then we have to look into which people are at a higher risk of having short birth intervals, and then to have evidence-based interventions that target those groups effectively. So this leads me to talk about the social demographic determinants of short birth intervals. And these are some conditions that have been documented in the literature that affect birth spacing. One of them is women's education. A study that was conducted in Karak, Jordan, found that there was a link between higher education and longer birth intervals. This can happen because women with higher education can delay their marriage, they can adapt their reproductive beliefs and norms, and they can have a more effective use of birth control. Young maternal age is another factor related to birth spacing. It was found in Tanzania in 2012 that non-adherence to the WHO recommendations was linked to young maternal age. This has a biological explanation as well. Of course, women who are young are more fertile than older women. But if you combine young maternal age with low socioeconomic status and with lack of education, this can put that group of women at a higher risk of having short birth intervals. Women's place of residence is also a factor that can affect short birth intervals. In the same study that was conducted in Tanzania, it was found that women who resided in rural areas had a shorter birth interval than women who resided in urban areas. This can be due to lack of access to medical care as well as low socioeconomic status. The parity of the woman also can be a factor, because in a study that was conducted in 2007 in Saudi Arabia, women who had only one live birth were more likely to have shorter birth intervals than women who had 2 or 3 children. Occupation in Nepal, it was found that women who had an employment status had longer birth intervals than women who stayed at home. So we can see that all of these factors can be interlinked with one another, and we need to know which groups are at risk of short birth intervals, and we see that there is this relationship between these aspects and their likelihood of having short birth intervals. In the United States specifically, there's a racial component. In the study that was conducted in 2014, it was found that Black mothers had shorter birth intervals than non-Black mothers. In figure 2, we can see that the percentage of mothers who had intervals of less than 12 months was highest among Black women, and it was lower in non-Black women. This is a national trend as well, and we can see here in this figure that between 2006 and 2010, the highest percentage of women who spaced their births at less than 18 months were non-Hispanic Black women at 39%. It was followed by non-Hispanic white women and then by Hispanics. We can see that if we look into the United States specifically, we have to target African American women in order to decrease the number of inadequate birth spacing. So this leads me to talk about the prevention methods, what's available and what we can do about it. And today I'm going to talk about 2 of these methods that have been documented in the literature to be effective and to work for groups that are of low socioeconomic status and that have the conditions that we talked about. One of them is the lactational amenorrhea method, and the second one is the use of contraceptive advice before, during, and after birth. So the lactational amenorrhea method relies on the fact that the woman has to undergo lactational amenorrhea. This is the temporary infertility that occurs when a woman is fully breastfeeding and she's not menstruating. Here in this figure, we can see the physiology of the lactational amenorrhea and what causes the women to be at this non-fertile state. So it all starts with the suckling, then that will alter hypothalamic and pituitary function, that in turn will affect ovarian function, and that will cause amenorrhea. The woman would not menstruate that month, and she won't have the possibility of getting pregnant. Here is a figure of the lactational amenorrhea method and how it works. So we can see that 3 things need to occur in order for the women to be protected with this method. First, she doesn't have to menstruate that month. Then she has to be fully breastfeeding, not supplementing with anything, and she is not going through long periods of time without breastfeeding. The child has to be less than 6 months old, and if all these 3 things are happening, then the woman doesn't need another form of birth control, and she will be protected about 98% that month. If any of these things are not happening though, then the woman has to have another form of birth control, but of course she has to still breastfeed her child. I think that this specific figure is very interesting because it highlights the benefits that breastfeeding has, not only for birth spacing, but also to create this cycle of health for the infant health and for the maternal health as well. So breastfeeding is interlinked with birth spacing, and birth spacing is linked with breastfeeding. Breastfeeding will help the child gain its nutrition, which will help with his or her survival. Birth spacing helps the mom attain a better health and can take better care of her child, and that will create this cycle where breastfeeding is a very good option for maternal and infant health. So we can start seeing that there are some strengths and some limitations to this method. Some of the strengths include that it is low cost, it is readily available, it is highly efficient if it's used correctly, and it does not expose the child to exogenous hormones. In population where contraceptive use is very low, it can be a very good option to delay a pregnancy right after a birth. And in terms of religion, ethnicity, and socioeconomic status, it's a method that is pretty acceptable throughout the world, so that is a major strength of it. Of course, as we talked before, there are those limitations, that time constraint of the age of the child. If the child is older than 6 months, another form of birth control is needed, and if the woman is not menstruating or not fully breastfeeding. So this leads me to talk about contraceptive use, what to do after the lactation and amenorrhea method. And studies have highlighted that there is a benefit of giving contraceptive advice before hospital discharge. A study conducted in 2015 in the Dominican Republic and Nicaragua found that women want to know about birth control before they leave the hospital after a live birth. In this particular study, 75% of the women who had a delivery said that they received or that they would have liked to receive a form of contraceptive advice before they leave the hospital. These results were also confirmed in 2016 by another study which said that contraceptive advice before hospital discharge is a good option. Another way to promote contraceptive use is to provide counseling regarding family planning at the prenatal care visits. A study done in 2013 found that there was an association between postnatal care visits and subsequent fertility. They found that the odds of having a second child and fewer than 18 months were higher when the woman started her prenatal care in the second trimester as opposed to in the first trimester. These odds increased to 26% if the woman initiated her prenatal care at the third trimester, and it increased up to 61% when the woman did not receive any type of prenatal care. So we can see that it would be a good strategy to provide counseling at prenatal care visits, especially to those women who initiate their prenatal care late, because they can be at a higher risk of spacing inadequately their births. So to conclude, I want to give you those takeaways. So it's necessary that women improve to improve mothers' education as well as other socio-demographic characteristics. It has been noted that it's feasible and effective to integrate family planning services to programs that target maternal and infant health. And as in anything in public health, we need to take this multi-level approach where we take into consideration public health interventions as well as legislation, as well as practices that are targeted at the individual and at the community level, so that we can have postpartum contraceptive advice, and that way we can lengthen birth intervals. Thank you.